Hey guys, hey, Dr. Ash here, coming to you with some concepts around inflammation. More specifically, we're going to talk to you about peptic ulcer disease, hernias, inflammatory bowel disorders, gallbladder issues, and then glomerulonephritis. So again, as one of my students told me today, down and dirty with the ICU nurse. So down and dirty is what we're going to do. Very quick to the point, what it is that you need to know about these disorders in order to be successful in your nursing test. So just as a general overview, these are risk factors for just about every GI issue that you can think of. So when you start talking about what am I at risk for, these are the things, or, in regards to the GI disorders, at least, these are like your heavy hitters. So allergic reactions, some sort of endocrine disorders, chronic alcohol use is good for causing GI distress, high stress level. So this is your wake up call. You need to get that stress under control. Chronic laxative use. There are some populations that actually abuse laxatives, and so that's going to put them at higher risk. NSAIDs. This is going to be a big one. Naproxen, ibuprofen, aspirin, Celebrex. Any of those NSAIDs are going to be harsh on the stomach. Of course, our diabetes, a family history, people with neurological disorders, and tobacco use, because as you know, tobacco causes vasoconstriction, and our GI or gastrointestinal area, as well as our abdominal cavity, is full of capillaries and blood vessels. So it's a highly vascularized place. And when we constrict those vessels, we limit blood flow, which is imperfusion, which is a whole nother topic for you to learn if you're interested in. So let's start with peptic ulcer disease, or PUD. And so basically this is just where an ulcer or an erosion forms somewhere in the wall of the stomach, pylorus, duodenum, or esophagus. And so this erosion may actually extend into the muscle, so we have to be very careful of that. We have three major types. We have gastric, we have duodenal, and then we have esophageal. And we are actually not going to talk about the esophageal in this particular video. That would be another video for another time. We are going to focus on gastric and duodenal because those are the two most common types of ulcers that you're going to find in our patients. And so at the end of the day, in order to diagnose, because I cannot see through your body, you cannot see through your body, the only way to do that is to undergo an esophagogastroduodenoscopy with biopsy, or EGD for short. So remember, that is the only way to diagnose a peptic ulcer disease. You can be suspicious of it because of symptoms, but at the end of the day, it's going to be the EGD with biopsy that tells you. All right, let's talk about gastric ulcers. These are specifically in the mucosal as well as the submucosal lining of the stomach. Again, these risk factors, not that much different from what we already talked about: stress, smoking, chronic steroid use, NSAID use, alcohol, gastritis, a family history. And then something you're going to see recurrently here are these H. pylori or Helicobacter pyloric infections. All right, gastric ulcers and assessment. What you're going to find are your patients actually have anorexia. They have no appetite because their stomach is on fire. Nausea and vomiting, headache. They have that reflux where it just feels like burning up into the esophagus. There's going to be abdominal discomfort, a very sharp pain, either in or just left of the epigastric area. And it is most common 30 to 60 minutes after a meal, because that is where you're at your highest digestion. So the stomach acids are at their highest while it's processing food. So therefore, you have most pain during that time of digestion. A very sour taste in the mouth. What you're going to find is if they vomit, they may have signs of blood in the vomit. Hematoemesis, if you will. And then also, if you guys recall, if you don't, there's a video on that as well, and talking about the different anemias. But B12 deficiency actually comes from damage to the intrinsic factor of the stomach. So that ulcer can actually damage that intrinsic factor, which causes a B12 deficiency. And again, we go more into the anemia in our anemia videos. So as far as from the nurse's perspective, you want to always assess for bleeding. This is always going to be one of the things that you definitely want to pay attention to. Small frequent meals. If you haven't noticed this yet, nursing loves to ask you about small frequent meals, but we're going to up that and say bland. This is not the time to have spicy, fried, high salt foods, high flavored foods, because that's just going to inflame that gastric ulcer even more. We have two major big types of drugs that we use to treat gastric ulcers, and it's not really all that necessary to know the difference between the two. At the end of the day, they're just used to reduce ulcer, stomach acid. So that's their whole purpose. H2, which is a histamine 2 receptor blocker or antagonist, and what we call a PPI or proton pump inhibitor, which are affectionately recognized by their ending of prazole, P-R-A-Z-O-L-E. So those PPIs are going to be kind of your top heavy hitters, if you will. And of course, what do nurses do? We teach. So we ask them to avoid all of those things that will complicate or exacerbate or make worse that stomach ulcer. So very important for you guys to understand, that's alcohol, caffeine, chocolate, that depresses me, smoking, and of course, NSAIDs. And we want to teach about stress reduction as well. So let's move into the duodenal ulcers. The duodenal or duodenal, depending on where you come from, that's actually a break or an ulceration, erosion, whatever term you want to use in the duodenum. And so again, our risk factors don't look that much different. Okay, it's still all the same things, but again, notice that H. pylori is popping up again as well. So on assessment, what you're going to find, and this is distinctly different from this gastric or stomach ulcer, is there is going to be burning pain in the mid epigastric area, anywhere from 1.5 to 3 hours after a meal. And that is because you have already digested that food. That food has moved along. It is no longer in the duodenum. It is no longer helping coat or protect the ulcer, if you will. And so therefore, that's when the pain increases. How do we fix it? We eat again. The problem with the stomach ulcer, food makes it worse because of increased gastric production. With the duodenal ulcer, it actually gets better when we eat. So that's kind of one of the ways that you talk to your patient to determine what kind of ulcer you think it is. This pain will actually awaken people at night. Think about it. When is your stomach the emptiest? Your stomach is emptiest in the middle of the night. And so a lot of times people wake up with that heartburn or burning sensation in that epigastric area. And then we also have the term melena. So as with the stomach ulcer, you're going to have blood in the emesis. With the duodenal ulcer, you're more likely to see the blood in the stool because it has to pass through the colon, right? We're past the stomach. And so that blood kind of travels through the GI system. So complications that we have to remember for our duodenal ulcers, they're important for your stomach ulcers as well. But most specifically, we want to talk about these duodenal ulcers because we're further down in the GI system. And so, of course, bleeding. All these ulcers have the likelihood of bleeding. In fact, a lot of times that is what prompts people to go to the doctor. I always like to say nobody gets worried till they see blood. The burning pain for the past 6 months doesn't bother you, but the moment you vomit blood, well, that's when you go to see somebody. So bleeding is definitely a major complication. Perforation. Ulcers can perforate, which means they burst through and rupture whatever area that they're in. And so what you're going to see on assessment is a rigid board-like abdomen. Once you have that very firm, rigid belly, that's your number one sign of a perforation. Hear me when I say that. It then requires immediate intervention. So you can see this a couple of different ways. This concept can show up a couple of different ways, right? It can show up as the patient is complaining of severe pain. When you assess the abdomen, it's very firm and rigid. What is kind of your next action? Call a physician. or it could be what's the number one sign of a gastric or an ulcer perforation, not gastric, ulcer perforation. But if only nursing school was that simple, right? The other thing with ulcers is they can actually cause a gastric obstruction. So we have to be careful of that, in which case, if you're concerned, you would assess those bowel sounds, right? If we have an obstruction, we're going to have some issues with that. And then something called intractable disease, which is actually outside of the scope of what I want to talk about because we're not quite there yet. All right, from the nursing standpoint, of course, we want to assess for the complications, look at that small, frequent, and bland meals again, because we can't go inflaming that with some Takis or anything spicy. Again, if it's an H. pylori or pyloric, whichever one you want to call it, infection, we definitely want to treat that. And that's usually treated with double antibiotics, antacids, the histamine 2 receptor, or the proton pump inhibitor. Although most of the time, about 99% of the time, you're going to see it double antibiotics with a PPI. So remember, look for those prazols, and prazols decrease gastric acid production. Okay, so that is your key here. Again, the teaching is going to be avoiding all those risk factors, because if we don't have the risk factors, we can't have the ulcer. So get that stress, caffeine, smoking, and alcohol under control, y'all. All right, let's talk about hernias really fast. So we have several different hernia types. We have the inguinal and the femoral, which happens to be in the groin area. We have the umbilical, which is our belly button or navel. We can have anywhere we've had a surgical incision. This is called a ventral hernia. Or we can have what's called a hiatal hernia, which is actually a weakened area in the diaphragm, which is, of course, that major muscle that splits your abdominal cavity from your chest cavity. Now, why do I have the first 4 starred? That is because they are something called reducible. When hernias are reducible, it just means they can be pushed back into place. All right. Because at the end of the day, a hernia is just a weakened area of the abdominal muscle. Inguinal tells you where it's at, femoral tells you location, umbilical, hiatal, that gives you an indication of where this is happening. And of course, you can't reach into your body and touch your diaphragm and reduce that hernia. So that's why that one's not starred. But any of those other hernias, you can actually lightly take your finger, push that bulging area, and push the intestinal material kind of back where it belongs, which is a little freaky if you think about it. But let's talk about inguinal and femoral all together. The most common of these two are actually going to be the inguinal hernias. So it's a weakening in the abdominal wall. And basically what happens is what I just said, which is the intestinal tissue pushes through that weak area and it creates a bulging through the skin. Now, your inguinal is most common because you actually, not all of us, but the male, genetic males in our group have an inguinal canal, and this is the track that the testes take to descend as they are born in that newborn kind of late fetal, early newborn stage, depending on where they are in their development. And so what happens is they're kind of at risk, right? They lift, they bend, they cough just right. That area gets weakened, and it oftentimes will protrude as a bulging area in the groin area. There can be some pain with lifting, coughing, bending, etc. I will tell you that our weightlifters tend to have a higher risk of inguinal hernias just because they do a lot of weight lifting, a lot of heavy lifting, and it puts strain on that lower pelvic area, which then in turn causes that bulge or that hernia. So just kind of FYI. Also, obesity would contribute to it because of the pressure in the abdomen. So really buff people or really fluff people, whichever one you want to pick. Treatment. Now there are 2 types, well, not 2 types of treatment, but if the hernia becomes what we call incarcerated, which incarcerated means jailed, right behind jail, in the body, it means that we've cut off blood supply. And that would require immediate surgical intervention. However, if it's just kind of bothersome and just kind of there, surgery oftentimes will be optional. So may or may not require surgery. Of course, if surgical intervention happens, we would want to do vital signs, address the pain, and ice. I'm not sure what redness means. I think we're assessing for redness and drainage. So I think my fingers got the best of me on that one. But vital signs, pain, ice, and redness or drainage is assessed. The other thing, and this is just kind of a surgical, very general surgical thing, after a repair, you always want to make sure your patients are up and walking around. They're getting plenty of hydration. They're voiding frequently. We want to make sure they're going to the bathroom very frequently. And then we also want to make sure that we rest, ice, and elevate the scrotal area because they will have swelling in the scrotum. The umbilical hernia, that's just a weakened area around the belly button that pushes out. It's usually soft, can be pushed right back in, but it is a bulge right in the belly button area. It can be present at birth or in severe obesity. I've actually seen an old wives' tale of women taping a quarter to their brand new baby's belly button. It pushes that umbilical hernia back in. And I guess it works for them because it actually causes the muscles of the abdomen to grow back to where they need to be. So usually not painful. If it becomes too large or it impairs, activities of daily living, it's all about, does it impair your ability to function on a daily basis? If that happens, then they'll go in and do a surgical repair. And again, this is one of those things, we don't want them bending, lifting, twisting, doing anything that's going to pop that hernia back. Of course, we also talked about the hiatal hernia, and this is just a pushing of the bowel and stomach through the diaphragm. And so we have some major risk factors that go along with this. Of course, obesity, pregnancy, if they have ascites or fluid in their belly, any tumors or heavy lifting. Again, those weightlifters are going to be at higher risk for the hiatal hernias. They do come with quite a bit of complications: ulcer, hemorrhage, vomiting. Of course, if something's pushing in on your diaphragm in your stomach, of course, you're going to have some reflux or aspiration or vomiting. And then it could be strangulation, or of course, that again is also incarcerated, where there's lack of blood flow to that area and can eventually cause necrosis, which is not a good thing. Assessment findings, they usually complain of heartburn, vomiting, dysphagia, which is difficulty swallowing, and a sense of always feeling full. Like it doesn't matter, even if they haven't eaten for 2 days, they still feel full. So some considerations that we keep in mind, again, those small frequent meals. We want to limit fluid intake during meals because the meal itself, food intake, nutrition is more important than the hydration. And then you want to tell them to not lie down after a meal for up to 1 hour. You want to make sure that the belly has fully digested before they start to lay down, or otherwise they're going to have some issues with heartburn or maybe even vomiting with that hiatal hernia. Let's move on to your inflammatory bowel disorders. Everybody loves inflammatory bowel, right? Irritable bowel syndrome, or IBS, is just a very general term for you got something going on, but we really don't know what it is. And so this can be chronic recurrent, either diarrhea, constipation, and or abdominal pain and bloating. And so that's why I kind of call this the general irritable bowel syndrome. It's a very generalized, we just slap that on you when you don't really have a definitive diagnosis, because it can be anything. It can be diarrhea, it can be constipation, or it can be bloating, or all of the above. Causes typically are environmental. It might be your immune system acting up. It could be genetics. It could be hormones acting up, or it just could plain old be stress. Some people have severe diarrhea before test taking, and that is 100% stress related. For your IBS patients, you want to increase dietary fiber, drink 8 to 10 glasses of fluid a day, and then of course medications for symptoms, symptom management. And what I mean by that is, if you have diarrhea IBS, then you would take like something for diarrhea. If you're a constipated IBS, you would take something to help you go to the bathroom. So it just really depends on what type of symptoms you're experiencing with your IBS. Next, we'll move on to the two big ones, which is going to be ulcerative colitis and Crohn's disease. So in ulcerative colitis, this is actually an inflammatory process of the bowel, and it can develop ulcerations. The biggest thing with ulcerative colitis and Crohn's as well is it's a malabsorption state. So you don't absorb the nutrients that you should. The interesting thing to me about ulcerative colitis is it actually starts in the rectum and moves its way up through the bowel. UC also has periods of remissions and exacerbation. So there are times when it's flaring up, if you will, and there are times that it is laying dormant. Now, eventually what's going to happen is this constant inflammatory process over and over again is going to cause scar tissue to form. And then eventually the bowel will actually lose its elasticity. So as it stands right now, your GI tract will contract and expand depending on whether or not you have feces in the bowel or you are empty. So that elasticity actually goes away over time because of this inflammatory process. So we have some major complications that I want to talk about. Number one is a fluid and electrolyte disturbance. If you don't hear anything else that I say today, please understand that both UC and Crohn's comes with a severe fluid and electrolyte disturbance. Not only is it a fluid volume deficit because of the chronic diarrhea, but you also lose lots of nutrients. So you're going to lose potassium and magnesium. Why are those important? Those are the two electrolytes that are most important to your heart. Your heart cannot contract and beat the way it should if you lose too much potassium or magnesium. And so one of the things that you want to do with these patients is make sure if they're admitted for a fluid volume deficit, we have to put them on a cardiac monitor. We have to watch that heart rate and rhythm. Okay, mandatory that you do that. Lower GI bleeding because the ulcer will actually erode or push through the bowel wall. Your patients can obtain abscesses, which are local pockets of infection, and that's just from where the wall has inflamed and weakened, and the infection kind of gets trapped in that inflammation. And then we have something called a non-mechanical bowel obstruction, and this is a paralysis of the bowel, okay? It's not a physical obstruction that's happening. Basically, there's portions of the bowel that become paralyzed and it just can't move. It can't have that peristalsis that happens. So what I like to associate this with is a hair tie. And so I'm female and I tie my hair back. And I notice that over time, that band that I hold my hair back with loses its elasticity the more I push and pull on it and strain on it and use it from a day-to-day basis. So your bowel's the same way. Once it inflames and it gets bigger and then it shrinks and then it gets all inflamed again, that stretching and contraction of the bowel will actually cause a paralysis over time. So some of your assessment findings you're going to see are loss of appetite or weight loss, fatigue, abdominal cramping, again, that's severe diarrhea, malnutrition from the malabsorption, vitamin K deficiency from the malabsorption, which also puts them at risk for bleeding. Remember, vitamin K is needed for clotting. And then, of course, anemia because they're not getting enough nutrients. And on top of that, they may have some GI bleeding that's going on. So our nursing considerations, again, that heart rate and rhythm, I cannot stress that enough just because of the potassium and magnesium deficiencies. We're going to take vital signs, assess the bowel sounds, assess stool patterns and stool itself. And on this one, I know IBS, we said to increase fiber. Once you're diagnosed with ulcerative colitis, we are now looking at a low fiber diet because we do not want to overextend that bowel. So we're looking at a low fiber diet. We want to make sure it's high in protein because they are malnourished. So we want to get as much protein as possible. And there are a couple of other foods that we want to limit. Okay. We want to limit nuts, milk, raw fruits and vegetables, peppers, alcohol, caffeine, and whole wheat, whole grains. All right, because those are going to be harsher on the stomach, harder to digest. It's going to put more stress on the stomach. But if you can handle low fiber and high protein, the rest will all fall in place. And of course, some of this stuff goes along with the risk factors. All right, let's talk about Crohn's disease. Crohn's disease is an inflammation of the GI tract, and it actually will lead to thickening, scarring, narrowed passages because of that thickening, right? The hole is going to get smaller and smaller and smaller. Again, fistulas or holes or openings, ulcers, and abscesses, or again, those pockets of inflammation or infection. Okay, assessment findings, we're going to find that they usually have a low-grade fever. They complain of cramps and diarrhea, abdominal distension, again, weight loss, nausea, vomiting. Again, these patients are malnourished, so malabsorption. So we expect to see anemia, dehydration, and again, those electrolyte disturbances. I cannot stress enough that these two are highest risk for electrolyte disturbances. All right, so let's move over to the gallbladder. How much fun is that going to be? All right, so cholecystitis, that is a fancy term for inflammation of the gallbladder. It can come two different ways. It can be an acute attack that typically happens because of the formation of gallstones, which is also called cholelithiasis. Or it could be chronic, and that's associated with what we call a sludgy gallbladder. Sludgy means that the bile doesn't drain very fast, it drains very slowly, and so therefore the gallbladder gets backed up and cannot do its job. So one of the two are going to be kind of your causes. Assessment findings: nausea, vomiting, indigestion, lots of gas from both ends, guys. I'm not trying to be funny, but it'll come out of the front and or top and the bottom. Epigastric pain that radiates into the right shoulder. Oftentimes they say that it hurts all the way through to the back and then will travel up to the right shoulder. Pain in the right upper quadrant, especially after high fat meals. Tachycardia, fever, and dehydration. So let's talk about glomerulonephritis to wrap this little puppy up. The other thing about the gallbladder, sorry, that I wanted to say really fast, you see that there's not a lot of nursing interventions. I don't go into all of that because really the treatment is to take that gallbladder out. And in that case, we're going to turn into a post-operative general surgical considerations. And we're not talking about surgeries specifically or general surgical care in this particular video. So just remember, cholecystitis is really kind of understanding where it's coming from, identifying the symptoms, so you can make recommendations for this patient. All right, so let's wrap it up with glomerulonephritis. Kidneys are one of my favorite organs. I do love to talk about it quite a bit, but I'll try not to run too long because I know we've already been here for a few minutes. So glomerulonephritis is just an inflammation or damage to the glomerulus of the kidney, which is where the term comes from. It's typically immunological in nature, which means you have some sort of immune disorder, usually an autoimmune disorder or some sort of immunological dysfunction that causes the glomerulonephritis. And so basically what's happening is it's secondary to some sort of infection. So your body starts fighting off this infection. It forms what's called these, without being an immunity conversation here, because that's a whole nother video for a whole nother time. But we have these antigen antibody complexes, and they're very large complexes, and they can get caught up in the glomerulus of the kidneys, which then turns into glomerulonephritis. So that's where that comes from. And over time, it will cause a loss in kidney function. So as you can imagine, we're going to talk about glomerular filtration rate, BUN, and creatinine. So again, causes, it can be autoimmune disorders. It can be some sort of immunological disorder. Typically, it's going to come because of group A beta hemolytic strep, also known as strep throat. So oftentimes these two can go hand in hand, and you can actually develop the glomerulonephritis about 2 to 3 weeks after this strep infection. Oh, and that's what I just said right here. So in the acute phase, that's going to be 2 to 3 weeks after that strep. Chronic is going to be gradually over time. Your body just kind of wears down, doesn't do what it's supposed to do, and then you develop glomerulonephritis. Complications of this: fluid volume overload all day long. When your glomerulus cannot filter, your glomerular filtration rate will go down because it cannot filter. And when it cannot filter, it holds on to fluid. So this is fluid volume overload. You have to monitor for fluid volume overload. Kidney failure, okay, it can be to the extent where it affects the BUN and creatinine to meet the criteria for kidney failure, which will, again, a whole nother video, so don't get wrapped up into it. Of course, pulmonary edema, but that comes kind of with fluid overload if it continues. Heart failure, and then of course seizures, and this is actually related to sodium, right? So when I have fluid volume overload, most people follow the theory of water follows salt, and so they automatically quickly tell me that it's hypernatremia, and it's actually the opposite. So when we're in fluid volume overload, we are hemodiluted, right? Because we have too much fluid in our circulatory system, which means our electrolytes get hemodiluted. So you actually have a very low sodium level, which is not good for the brain. The brain loves a very tight window of sodium. So you have to look out for those neurological symptoms. So assessment findings associated with glomerulonephritis: facial edema that happens to be worse in the morning, gets better throughout the day. Of course, decreased urinary output, loss of appetite. There may be blood or pus infection in the urine. Patients may become lethargic or fatigued, very pale. They may complain of back or abdominal, maybe even flank pain. Right in the kidney area, and then of course hypertension because they're in a fluid volume overload state. Again, for your blood values or serum values, you're going to see that the glomerular filtration rate is down, and BUN and creatinine start to climb up. Okay, so GFR goes down, BUN and creatinine goes up. Please remember that. Nursing considerations for this: vital signs, eyes and nose, daily weights. The single best way to determine fluid volume status is to do daily weights. So vital signs, eyes and nose, daily weights. We're going to put them on a sodium restriction simply because we do not want them continue to have so much fluid on board. So not depleting sodium, but we are going to be very well controlled on the sodium intake. We're going to assess for those extra complications: fluid volume overload, pulmonary edema, which would be crackles in the lungs, frothy sputum, that kind of fun stuff. We do anticipate administration of diuretics. What's the best way to get the kidneys to start working and peeing off excess fluid? That's to give diuretics. And on the back end of that, from a nursing standpoint, we need to monitor for effectiveness, right? We have to evaluate the E and the ADPI, if you will. So we have to make sure it's doing its job. Well, how do I know that diuretics are working, the kidney function is improving, and they are losing weight? There you go. Just that simple. And the seizure precautions, we already talked about the sodium, so I won't rehash that. And that is it, guys. Make sure you like, share, and comment if you found this helpful. By all means, we love all of the interactions that have been happening. Completely loving the fact that we are growing, and that is a good thing. So if there's any more content that you think of, please let me know and we will get that started. And I will see you in the next video.